In this presentation, we're going to demonstrate the use of 3D planning, robotic steering, in order to access a fairly unusual type 2 endoleak in the type B dissection. Several principles will be demonstrated here. First of all is the importance of evaluating endoleak geometry using multiplanar reconstruction and geographic evaluation of the flow patterns, the use of CTA to fluoro-CT fusion, which allows us to create a guidance system for the robot to deliver a septal perforating needle. This patient initially presented with the type B dissection. What's unusual, if you look at the inferior margin, is that the false lumen flows straight into the celiac artery, where the superior mesenteric artery comes off the superior mesenteric artery. Despite this, we opted to just go ahead and lay in an endograft in standard fashion, covering from the just beyond the left subclavian all the way down to just above the level of the celiac artery. And the patient tolerated this without any problems, no evidence of intestinal ischemia. A follow-up, however, they continued to have intermittent pain, and there's a very unusual flow pattern occurring within the margin of the sac, and you can see it depicted here. This began high up in the endoleak sac. Began high up in the dissection and flowed inferiorly down into the superior mesenteric artery. And on multiplanar reconstruction, it looked like it was flowing from a superior intercostal artery straight into the celiac artery. And there was no direct access to the type B dissection and the false lumen directly at all. So for this reason, we opted to go ahead and take a somewhat unusual approach. And you can see how it flows into the celiac artery, but the SMA itself was flowing off the true lumen. It's a little bit better easier to understand this looking at the false lumen on the surface rendered images, where you can see the celiac artery narrowed but flowing directly from the false lumen. On the workstation, we first of all did fusion of the previous CTA onto a cone beam CT performed on the table. And once this is done, it allows us to actually plan the route, and the route is actually planning is actually performed also on the workstation. First thing that we did was do an angiogram to evaluate the SMA to celiac collateral. So you can see the SMA angiogram showed it fills the hepatic artery and the superior mesenteric artery. On the workstation, we then planned the pathway. These yellow markers drawn on the computer will subsequently depicted on the fluoro system and overlaid on top of the patient. It's pretty easy to see the bottom end of the endograft. Here's the celiac artery. We can mark where the endoleak pathway is, and we can mark, you'll see a couple of X's that we're going to put on here, where we really want to put a needle from the true lumen right at the bottom of the endograft straight into this endoleak pathway. And so when you step on the fluoro pedal, this is what is overlaid on top of the patient, and you can see it's very accurate where the catheter is in the SMA orifice here. We're injecting the SMA, and you can see the celiac is filling and the splenic artery is filling. And so what was done next, then we switch over onto the robotic control system, and here's the robotic sheath, which is being positioned right at the determined target, right in this area here. We then advanced a needle, which was perforated through the septum. This is a balloon which supports the needle. The needle has a 4 millimeter throw, and you can see it coming at the right at the bottom of the endograft. When you advance the wire, it goes straight up and into the endoleak pathway. And you can see the wire is actually passing up this predetermined pathway, which we'd also marked and overlaid. Once you do that, you can actually put a catheter up in it, and you can inject. Almost looks like an artery, which is formed inside the false lumen. We then tracked a 4 French catheter over the wire. This is an 014 wire which had been advanced up into, and this allowed us, there's a 3D overlay, starting to lay coils from almost the very top of this persistent endoleak pathway all the way down to the celiac artery. We considered fenestrating the inferior margin, but opted just to go ahead and embolize this entire pathway. And at follow-up, the patient was completely asymptomatic, had been discharged the following day, and in follow-up, the entire false lumen has been occluded, and the patient did remarkably well. What we essentially have then demonstrated is that there are some very complex pathways, we've demonstrated that the importance of multiplanar evaluation of the pathway, geographic evaluation of the flow patterns, CTA to fluoro-CT fusion, and using workstation guidance, we very precisely introduced a needle across the septum using a catheter robot. Thank you very much for your attention.